Hey class, this is Logan. I'm gonna be doing a kind of a talk through protocol AC6, which is the adult tachycardia, the narrow complex. The reason why I picked it was I was kind of having a hard time remembering the difference between monomorphic wide and tachycardia narrow, kind of getting the two switched up. So that's why I just went with narrow. So something that I kind of want to bring up is some signs and symptoms that are common or seen often with this. So we have common things that you can see in the field, I guess I should say, is chest pain, some heart failure, dyspnea, which is difficulty breathing, some AMS, altered mental status, shock, poor perfusion, and hypotension. Some other things you can see is some pale or diaphoresis, skin types, shortness of breath, nausea and vomiting. And when I'm talking about narrow, just to clarify, we're talking a QRS complex of like 0.11 or less. Now, something that I kind of just want to bring up, now obviously these slides will be posted so you can kind of follow through the video if you'd like. Some important side note things are when you're dealing with these patients, you want to be a good investigator, ask certain questions such as age, OPQRST, and samples are huge, but kind of some big bolded questions that can be really helpful to kind of maybe have more high index of suspicion of some certain things would be like your age, past medical history, and time. And when I mean time, we're talking about when did it happen, how long did it last, and is this a repeating thing? What is the interval like? And a big one is, were you doing anything strenuous when it happened? That's a big one. Now differentials. Mr. Parker's always talking about differentials. What are differentials? Just to kind of clarify, I feel like this gets brought up a lot. This is super important. Differentials are kind of allows you to have an index of suspicion of other potential illnesses, injury, illness, or disease, something like that. Now, why should we think about differentials? The reason why we should think about differentials is because we're kind of keeping our minds open to other possibilities. Helps us not be closed-minded, and kind of opens our minds to not get so fixated on something that kind of ruins our potential treatment plan. So it allows us to rule out also other possibilities, which is helpful for us as paramedics because we can't diagnose anything. So kind of ruling out certain things so we can plan our treatment plan accordingly. And overall, just kind of helps us make better decisions. Now with AC6 differentials, let's think about some things. Like, is this a trauma or a medical situation? What's causing this problem? Now, with sinus tach versus like a dysrhythmia, kind of knowing that underlying rhythm is important, so pay attention in cardiology. Some other things we could be thinking about is fever, sepsis, infection, certain things like that. Always think about the possibility of PE, pulmonary embolism, in this. That's why getting like past medical history is really important. Or like a aortic aneurysm or something like that, because it could show similar signs and symptoms of what this is. And then there's another one. Overdoses on beta blockers or anything, or stimulants, kind of, again, getting their past medical history, seeing if you're dealing with something along those lines. Now, finding the cause of the tachycardia is huge. Mr. Parker's always talking about finding that underlying rhythm. It is really important. Now, if this rhythm is unstable or has some serious signs and symptoms, or the heart rate is greater than 150 or 150 or greater, I should say, you should consider some things. Now, if it is a regular or narrow complex, consider like adenosine, which would be 6 milligrams, IVIO. It's going to be a rapid push, and you can repeat that up to 12 milligrams IVIO as well. Now, if those things don't work, and we're talking about, again, the unstable issue here, then you could consider other options such as like synchronized cardioversion. But just remember that if you're going to do that, you should be considering sedation. So midazolam or Versed, which would be 2 to 2.5 milligrams IVIO, and a maximum of 10 milligrams. And then for that, when you, after sedation, getting your patient comfortable, the joules, like if you have a narrow regular complex, you're going to be doing 50 to 120, or no, 50 to 100 joules. And then narrow and irregular would be 120 to 200 joules. So just keep that in mind. Some other takeaways here. Remember that some notes I had in here. Patients like this really need to be on a 12 lead as quickly as possible. Always have the monitor visible and pointed in a direction that you can always check it easily. Following IV and IO protocols will be needed here. And then just remember, something we can really take away from pharmacology is, if you're going to stick your patient, just remember or think about why you need to establish that line instead of just worrying about getting a successful stick. Like, do you need access? If we do, why is that? Now, if those things don't work, we can consider going some different routes and options. So, like if the rhythm is regular, we could go the route of attempting like a vagal maneuver, or doing, if say the vagal maneuver doesn't work, you could do 6 milligrams of the adenosine again, the IVIO. Just remember that's a rapid push, and you can repeat it up to 12 milligrams. And then if the rhythm is not regular, there's some other treatment plans we can do. Now, for those irregular rhythms, we have our cardizem, or I struggle with this word, ditalizem, which is going to be 0.25 milligrams per kilogram, I believe, of IVIO. And then you're going to have to push that over a certain amount of time, which I believe is 1 to 2 minutes, or 2 to 3 minutes. And your maximum of that is going to be 25 milligrams. If there's no improvement in that, you can go a different route, which would be, again, cardizem, but you could do 5 to 15 milligrams an hour. If no improvement happens with that, you'll still stick with cardizem, but you can do, it's 0.45, no, 0. I don't want to look, but I might have to. It's not 0.45, it's 0.35 milligram per kilogram, I believe. Might be. I hope I'm not wrong on that. But still, a maximum of 25 milligrams. And then, if that doesn't work, again, we're trying to slow this down. So amiodarone could be established. So you do your normal 150 milligrams. Just remember that needs to be in 100 mLs of like, I believe it's like D5W. Now, amio would just help kind of stop those impulses in the heart from going so fast. And then you can use, I know, like depending on the agency, like specific beta blockers, so your LOLs. And then some pearls to look out for. I know, I did write these down. Let me see if I found them. Yeah, so some recommended exams in pearls, like mental status, obviously, skin, neck, lung, heart, abdomen, back, right, extremities, neuro, we talk about this, but really getting your hands on your patient, really checking out all those things. And again, if you're doing that, you're able to rule out some more differentials and stuff like that. Now, most important goal is to differentiate these types of tachycardia. Is this stable? Is this unstable? And is it symptomatic? Because you could, see something crazy on the monitor, but your patient is totally okay. So remember to treat your patient, not your monitor. And then just that 12 lead EKG, not necessarily, you wouldn't be able to necessarily diagnose or anything like that and treat sometimes, but obtain it when the patient is stable and you're able to do that. Sorry, excuse me, guys. And then last thing I have here is just a little side note. Some unstable conditions with like that impairs like some vital organs or like the functions of those big ABC things that we talk about. You need to be looking out for that arrest that possibly could be happening sooner than you think. If at any point patient becomes unstable or moved to some kind of unstable position, be ready to look for seeing underlying issues such as like sepsis and like obviously dyspnea, and then what goes along with fever and all that, and fever and sepsis. And then I do have a note here. Depending on the age, just remember that sinus attack can run a heart rate of 100 and 200, but usually a symptomatic tachycardia is shown after a heart rate of 150 or greater. And just be ready to treat cardiogenic shock or cardiac arrest. And then lastly, some severe signs and symptoms to look out for. Hypotension, obviously, AMS, shock, poor perfusion, and like T-wave depressions and inversions of those T-waves. Just those are some things to be aware of that could lead you to some of those very unfortunate events. Again, my name is Logan Comfort, and that was AC6, narrow tachycardia complexes for the NC protocols. And that's all I have. Thank you.